Hi, everybody. Good evening. Welcome to our December issue of Facebook Live. I'm Susan Thornton, and it's really great to have everybody with us here, headed right into the holiday season. So if I forget to wish you a happy holiday, I really wish everybody a very happy holiday season and a great 2019. So tonight is going to be the first in a three-part series of discussing topical skin-directed therapies. And our guest this evening is Dr. Daveluy from Wayne State University in Michigan. Good evening, Dr. Daveluy. How are you tonight?
Good evening, Susan. I am great. Thank you so much for having me.
Yeah, it's really great to have you with us. And, as patients, topical therapies, skin-directed therapies are obviously a huge part of how we treat disease. And even for those folks that may have a little more challenging disease or systemic disease, topical is still a big part of the overall therapy regime. And things can change and modify over time depending upon how someone's disease shows up or what treatments are working or not working. So thank you for taking on the task of providing us a framework for this first part of the series and the overview of skin-directed therapies and a little, so we all kind of can come to the table with some understanding and appreciation. So I know you have a presentation to kind of walk us through and get everybody on the same page. And then once we're through with that, we'll open it up for questions. And you can type in your questions at the bottom of the page, and we'll take them as they come in. And hopefully this will be a nice interactive dialogue, and we'll take it and go from there. So I'm going to turn it over to you for the next few minutes, several minutes, as you walk us through the presentation, and then I'll come back on after you're done.
Sounds great. Thanks again, Susan, and thanks to the Cutaneous Lymphoma Foundation. This is a really great way to deliver some information to the audience at large, and I think it's really neat and really a cool way to do things, and I'm super excited to be involved. So like Susan said, I'll kind of do a quick overview with a presentation here of some of the skin-directed therapies and what we can do, and then we'll kind of go into the question and answer. So like Susan mentioned, a lot of times topical treatments are the first thing that we use to treat, and even if you have more advanced disease, we usually have some topical treatments going on even when you go to more advanced treatments. And so the first question is sort of, why do we do things that go on the skin if the problem is something going on in the immune system? And the reason is because the immune cells that are abnormal in cutaneous lymphoma sort of live in the skin. They move between the skin and the lymph nodes, but they spend the vast majority of their time in the skin. They have these little surface markers that are almost like a little address tag that lets them know to go live in the skin. So this is a picture of a skin biopsy of cutaneous T-cell lymphoma. And you can see the top part is sort of the normal staining that they do for any skin biopsy. And I don't know if you can make it out too well, but there's sort of these abnormal black dots along the edge of that pink upper area, which is the epidermis, and then that sort of less dotted area at the bottom, which is the deeper layer of the skin. But then at the bottom part of the picture, the smaller area, you can see they did a stain to highlight those abnormal T cells, and that's that yellow. And so you can see they really hang out at the bottom part of the upper layer of the skin, which means that creams and things you put on the skin can really get to them pretty well. So a few general things to think about with cutaneous T-cell lymphoma in general is that there's a lot, usually it involves a long-term follow-up. You're going to get to know your doctor who's taking care of you. You're going to get to see them regularly. Unfortunately, it's not something like a ringworm infection where we give you a cream, it's cured, and you're good to go. It's more of a prolonged remission or just getting things stable that is our goal. We do try to get the skin clear of disease whenever possible, and we also go after the symptoms, which are usually itch, pain, sometimes burning, and then that redness. And everyone responds differently, so it's always an individualized approach. So we're going to go over some general themes, but as always, talk to your doctor, figure out what's going to work best for you, what's going to go well for you, and if things aren't working, talk to your doctor again because they may need to switch things. So in general, the skin-directed therapies, things that are going toward the skin or treating the skin to try to treat the disease, go with topicals, which is what we'll really focus on today. That's your creams, which are like moisturizer, like creamy, or ointments, which are more like a Vaseline, petroleum consistency. And those are topical steroids, Mechlorethamine, Bexarotene, and other retinoids, and then Imiquimod. And then there's light therapy, which will actually be the focus of the next talk in the series, which includes ultraviolet B and UVA with psoralen, also known as PUVA. And then there's some other things too, like radiation therapy, and bleach baths, and this capsaicin cream that we'll talk about a little bit too. So the topical steroids are usually the first thing we go to. It's really the first thing we go to for a lot of skin diseases, including psoriasis, eczema. The way they work is to sort of inhibit the immune system, so it can inhibit a normal overactive immune system that we see in eczema or psoriasis, or it can inhibit the abnormal immune cells that we see in T-cell or cutaneous lymphoma. There's super potent steroids, such as one called clobetasol and another one called betamethazone, and there's some lower strength steroids as well that sometimes can work. It's really great for patches. As you may be familiar, the disease can come as patches, which are flat, plaques, which have a little substance to them and are raised, or it can advance to even tumors where they're thicker lumps in the skin. Generally, steroids can be inexpensive. So for example, it's $75 or $70 for a 45 gram of betamethasone. Some of them have a little price difference, but in general, you can find some more inexpensive ones. They come in creams, ointments, liquids, foams. Usually you put it on twice a day. Like I said, it's a really common first-line treatment for early stage disease. Sometimes that's all we need is some topical steroids to get it under control. And like Susan mentioned earlier, even if you go to advanced disease, you may still end up using your steroid to kind of treat it inside and out. The next topical is Mechlorethamine, or nitrogen mustard, or the brand name, one of the brand names is Valchlor. It used to only be available by a compound where you have to talk to a specialty pharmacy, but now it is commercially available as Valchlor gel. You put it on once a day. It is more expensive. It's about $3,000 for 30 grams, which isn't the biggest tube out there. It can cause some irritation and very rarely an allergic reaction, just an allergic skin reaction where you sort of get a rash from the gel. And it can take months to see improvement. It's not super fast. It can cause some hyperpigmentation, which means darkening in the areas that you put it, but that's temporary and does go back to normal when you stop. And a lot of times we'll combine it with a steroid to help prevent some of that irritation. So since it's once a day, maybe the other time of the day, we'll have you apply the steroid cream to sort of prevent that irritation and ease into it a little bit. The next sort of class of topicals are called retinoids, and the most famous retinoid is Retin A that we use for acne. They use it for anti-aging, but that one doesn't have as much evidence that it helps so much in cutaneous lymphoma. So the one that is really proven to work well in cutaneous lymphoma is Bexarotene gel. The problem with Bexarotene is it's very expensive. So it's about $30,000 for 60 grams, which may only last a month or two. You put it on 3 to 4 times a day. You can't use it in pregnancy because the oral form can cause birth defects, and they found that the topical form isn't safe either. It, again, can take some months. So as an alternative, there's one called Tazarotene that was actually originally approved for use in psoriasis. It's not FDA approved to treat cutaneous lymphoma, but there has been studies performed that show that it does about as well as Bexarotene gel, and it's much less expensive. So it may be something that your doctor may choose because it's more affordable and it seems to work just as well. One of the effects that retinoids have is they not only affect the skin immune cells, but they actually affect the skin cells themselves, and they can stop the skin cells if they're going too quickly and kind of growing thicker and growing flakes on top, scale we call it. So that's why it works for psoriasis, where it's thick and scaly, and that's why it's also good for people sometimes get the lymphoma on their hands and feet, and it'll get kind of real thickened, almost looks like a thick callus. And this, the retinoids like Tazarotene or Bexarotene can be a really good choice if you have disease in those areas because it can help to kind of thin it down a little bit at the same time. And then the last cream we'll talk about is called Imiquimod, or the brand name is Aldara. It's kind of an interesting thing. We use it for skin cancer. Sometimes we use it for warts, and then we can use it for cutaneous lymphoma. And it actually stimulates an immune reaction. And because the normal immune system kind of gets active where you're using it, it can recognize the abnormal immune cells of the cutaneous lymphoma and have the normal immune system attack them. And that's sort of how it works. For that same reason, though, when it stimulates the immune system in the area, it can cause irritation and even a rash. So one of the issues that comes up with Imiquimod is that it's FDA approved for treating precancers and cancers of the skin that aren't lymphomas, more like the sun damage type skin cancers that come along, squamous cell carcinoma, basal cell carcinoma. So it comes in small packets. So it's not something you're going to be able to use to treat a large area because it's kind of cost prohibitive to get it in all these small packets. In general, it's used when other treatments fail. It's not one of the ones that we go to first line. It's sort of a backup treatment. And then, as I mentioned, there's going to be a whole nother talk on phototherapy, so we won't get into it too much. But it is a way to get a treatment to the skin. We usually do it 2 or 3 times a week, and then once you're doing better, we taper down to less frequently. Sometimes traveling to the office and the copays can be an issue, especially if you don't live near an office that has it available. One of the advantages is you can treat your whole body, which may prevent new lesions. So instead of just putting a cream to where you already have disease, it can treat everywhere. So maybe it will prevent it from showing up in a new area. There's one type called PUVA, which uses ultraviolet light type A, and sometimes we use a pill with it. So that enhances it, so it goes a little bit deeper, but the pill can cause some nausea, which ginger can help to eliminate. And then there is a limit, because if you get enough of that PUVA therapy, it increases your risk of those sun-related skin cancers. So we usually limit it to 250 treatments or less. And one of the advantages of light therapy, if you do have that distance, is that you can get a unit for your home. Sometimes it's a challenge to get it approved through the insurance, but if you can get it, it can be very convenient. And then another skin-directed therapy that we won't go too much into today is radiation, which is sort of like an X-ray beam that they use to take an X-ray of your chest or of a bone, but a little bit different in terms of the dosage, which then makes it have a different effect. Instead of just going through the skin to see the bones, it actually has an effect on the skin. So you can use it for patches, plaques, or tumors because it can actually penetrate through the skin. There are some lower dosage regimens that have less painful reactions on the skin because it can cause sort of a sunburn-like reaction. And you can get it to the total body, but the difficulty with total body radiation is that it requires a special machine, and so it's not available everywhere. So it may require you to travel a distance to get those treatments. And then one of the disadvantages of radiation is that the relapses are common. So after treatment, their disease may flare up again, given some time. So this is just a little, like I said, there's patches and plaques. So this is a little chart that kind of goes over, depending on what type of disease you have and how much widespread it is, whether it be widespread or more limited and not in as many areas. It kind of helps your doctor to make those decisions on what would be the best treatment. So for limited patches, there's topical steroids, the nitrogen mustard, the Imiquimod, basically all the creams. If it gets down to plaques, yeah, the nitrogen mustard can still work, or you might need something that penetrates a little more deeply. And then, like we said, with widespread, the UV therapy can be helpful because it treats the whole body, the total body electron beam radiation. Those can be better choices for that. And then lastly, there's a few things that can help that aren't necessarily treating the disease themselves, but can still help the symptoms. So moisturizer is a huge part of that. Itch can be a really big problem, and dry skin is a big contributor to the itch. So even though the moisturizer isn't going to necessarily fight the disease itself, it's going to help to prevent that itch. So I tell everybody to make sure they're doing a good moisturizer regimen. Living here in Detroit, our winters are pretty brutal when it comes to your skin getting dry, because when we're running our heat, it just pulls the moisture out of the air and you get really dry. So that's a really good time to make sure you're using a lot of moisturizer. Putting it on right when you get out of a bath or shower is good because the soap washes away some of the natural skin oils and can leave you more dry. So like I said, it may not necessarily be the only thing you're going to do to treat it, but it's a simple step that everybody can take to make sure that they're doing everything they can to make their skin feel as good as possible. Another thing that specifically targets the itch is called Sarna Original, and it has some menthol, which gives that cool sensation on the skin. And it has pramoxine, which specifically helps to calm down the nerves in the skin and prevent itch. And then another topical cream that's available is called capsaicin. It's available mostly for arthritis, and it's made from hot peppers, like jalapeno peppers. So the first week or so that you apply it on there, it can give you a little bit of a burning sensation, but then it's like if you eat a hot pepper every day, it doesn't taste spicy to you after a while, because the capsaicin actually tires those nerves out from feeling the spicy. It does the same thing for itch nerves. So if you're kind of using it repeatedly, eventually those itch nerves just run out of juice. They can't react anymore. They kind of get tired of reacting to the capsaicin, and it can soothe the itch, as long as you can make it through that initial period of where it kind of stings and burns. Another thing that can also be important in cutaneous lymphoma is that the infection risk is higher in terms of the skin getting infected. And we think part of it is because normally your skin has a certain amount of immune cells there ready to fight infection, but in cutaneous lymphoma, a lot of those cells are the abnormal lymphoma cells, and they don't do much of a good job of doing what they're supposed to normally do. So it can make it harder for your skin to fight the infections. And sometimes that can drive the itch, that can drive flares of disease, and it can just drive discomfort. So one of the ways that you can sort of prevent infection of the skin is a dilute bleach bath, which at first when we say bleach bath, it sounds like it's kind of harsh, but basically you dilute the bleach down to about pool chlorine level. So you take regular bleach, and if you fill your bathtub all the way up, it's a half a cup. If it's only a half a bathtub, it's a quarter cup. You soak in it for 5 to 10 minutes, 2 or 3 times a week, and then you just make sure you rinse off. Otherwise, you might get that skin dryness that you get from pool chlorine. And that can help, and it actually has a little bit of a calming effect on the skin too. So that can be another thing that's sort of relatively easy to build into your routine that can contribute and help out a little bit beyond what prescriptions and everything can do. So that is it for the presentation part. And now we'll open things up to questions.
Great, great. So while people are thinking about their questions and posting their questions, I know Mike, our wonderful producer, will put them on the screen for us as they come through. So maybe we can just ask a few questions that have come in before, and we can get started, and that'll get people thinking. So what, you know, this disease obviously mimics other skin diseases. So what would, you know, someone goes to the physician, what would make a physician decide to do a biopsy, and what kind of biopsy should be done, and what kind of testing is usually done in order to look for cutaneous lymphoma or to rule it out, right, against something more common like eczema?
That is a great question. And one of the challenges with cutaneous lymphoma is, just like you said, Susan, it can mimic a lot of other things, including eczema and psoriasis. And there's even some evidence that your eczema may sort of go off on a different path and turn into cutaneous lymphoma. I'm not saying that that's a common thing that happens to most people with eczema, but it is possible where some people report having eczema for years and then sort of develop a different rash. So there's a few things that really make your doctor think maybe I should do a biopsy. The first could be if you have some of the particular findings that look more like cutaneous lymphoma than other diseases. So sometimes the cutaneous lymphoma can make the skin appear a little thinner. So one of the terms we use for that is sort of like cigarette paper crinkling. It sort of looks a little crinkly and wrinkly on top. And that might clue them in that, hey, maybe I need to do a biopsy. This doesn't look like a normal rash or a non-lymphoma rash. This almost looks more like lymphoma, and I'm a little more suspicious. The other thing is, if we suspect it's eczema or it's psoriasis, and we start some of the typical treatments, and it's really not responding the way we would expect it to, then that might prompt the doctor to say, hey, this isn't really behaving the way that psoriasis or eczema should. Maybe I should take a little biopsy to get a closer look. One of the challenges with lymphoma is that some diseases have a lot of the abnormal immune cells in the skin. So as soon as you take a biopsy, it's chock full of those immune cells, and the pathologist tells you exactly what it is. With lymphoma, it's a little trickier. There's not often a lot of those cells there, so it can kind of miss the biopsy sometimes, or the biopsy misses it. So sometimes it may take multiple biopsies, even stretched over a span of months to even years, before you finally catch it and sort of pinpoint the lymphoma. So don't be too discouraged if that is sort of the path that you got to lymphoma. Sometimes it's not so much that your doctor wasn't doing a great job and doing bad biopsies. It's just that's the way the disease is. It can be hard to catch it and kind of catch it in the act and actually make the right diagnosis. Traditionally, the way we did the biopsy was a punch biopsy, which is we use a little tool and take a plug of skin. And the advantage of punch biopsies, we use them in a lot of rashes because it gets sort of the full thickness of the skin from the epidermis to the dermis all the way through. So if there are some immune cells deeper, we can see them as well. But there's been some support more recently for if you suspect cutaneous T-cell lymphoma. Like I mentioned earlier, those immune cells are right there at the bottom of the upper layer of the skin. So there's another biopsy we call a shave biopsy, where it doesn't go as deep, but it's more broad and superficial. Not as deep, but more broad. And the advantage is you get a bigger area of that, they call it the dermo-epidermal junction, that little area between the two layers. So they found that that may actually be a little bit more beneficial because you just have a bigger area to look at and try to catch those T cells. Sometimes when you do the biopsy, all biopsies get this thing we call hematoxylin and eosin, which is H&E. It's kind of the basic stain that you use. They put some stains on there so that the cells will look different colors and the nucleus will look a different color. So that's kind of step one for all biopsies, is to stain with that and take a look. Sometimes with that alone, the pathologist can say, hey, these are some abnormal looking lymphocytes. I think this is a cutaneous lymphoma. Other times they have to do some more advanced staging, because there's certain changes that happen in those abnormal lymphocytes that make up the cutaneous lymphoma. And like I mentioned earlier, they have these little things on their surface that kind of tell them where to go and what to do and what kind of cell they are. It's sort of like their signature on their surface. And so they use those to stain and see, are these normal lymphocytes, or have they lost some of the normal signatures on the surface? Have they gained some other ones that they won't normally have? Sometimes they even look at the ratio of how many have this type versus how many have that type, and it can kind of help to make a diagnosis. And one of the tough things with lymphoma is sometimes the diagnosis is fairly easy to make. Other times it's a challenge. Even with the staining, even with advanced techniques, it's really hard to identify it. Which there's even some further testing. Some are in development where they're looking at to see if the T cells, they tend to be what we call a clonal population, where we think, one T cell was the original father and just went crazy and had a bunch of offspring T cells. And so they're all basically genetically the same. And so we have some tests we can do to see and to show that they're identical. And we can run those tests. And of course, no test is absolute, but those can also be really helpful. And in recent years, they've sort of advanced the field in testing for those clonal proliferations, those clone populations of the T cells, which has been really helpful in helping us to make the diagnosis, and sometimes to even tell if you get new areas, if it's the same as your other lymphoma or if it's sort of a different thing going on.
Great. And I think we've got some questions. I think our audience has been paying attention. So
Yes.
Let's see. Can MS be diagnosed with something else, and are the shaved biopsies accurate? So see, someone was actually listening.
Yes. So it's not too uncommon for it to, like I said, be misdiagnosed, especially early on. Sometimes the biopsy comes back and it's just not specific enough for us to say, yes, this is MF, which is mycosis fungoides, or cutaneous T-cell lymphoma. Those are kind of synonyms, two names for the same disease. So it's kind of difficult. In some studies, it took an average of 7 to 8 biopsies before they actually caught it. And like I said, sometimes it's literally just that the T cells weren't in that specific spot that we biopsied. So that's why we've kind of moved more toward doing the shave biopsies, because it does give us a little bit larger sample to work with. the punch biopsies, the typical one is 4 millimeters, which is about the size of a pencil eraser head. And so it's a pretty small area of skin to look at, whereas the shave, you can get a bigger area. So the shave does seem to be a little better than the punch, but it's still not absolute. There's still a chance that it's not going to show up on that biopsy. And it can be a little tricky because sometimes if at first your rash looks like eczema and your doctor gives you an eczema cream, if you're using the cream and it's not quite getting better, so they decide to do a biopsy, you actually need to stop the cream for at least a couple weeks before the biopsy, because that cream, like I said, it affects those T cells and it chases them away. And so if you're using the cream, then it's even more likely that your MF won't show up on the biopsy. MF or cutaneous T-cell lymphoma is the most sensitive disease when it comes to that, to the steroid actually making the biopsy less accurate. But it can be a challenge. That's why I always discuss that with my patients, that it's not uncommon that we have to do more than one biopsy before we catch it. And sometimes I have in my head where I'm thinking, I know this is cutaneous T-cell lymphoma. I know that's what this is, but my biopsy just didn't show it. And so I just do repeated biopsies until we do catch it. And then I go, all right, I knew that that's what it was. It finally showed up. And maybe it's even early enough in the disease that there aren't enough lymphoma cells there to really catch it on the biopsy.
Here we go. Can chlorine assist like bleach, for example, home hot tub use? So if somebody has a hot tub, can they go in the hot tub and put chlorine in it, and is that beneficial?
You know, that is a really good question, and I haven't specifically talked to people about it with their hot tub, but we do, because it is about the strength of chlorine. If someone has a pool, I usually tell them, yeah, you can just go in your pool 2 to 3 times a week and it'll have the same effect. So in theory, the hot tub should also work. Hot tubs can be a little trickier to make sure that the chlorine levels are just right. And then the other thing you have to watch with hot tubs is that sometimes the heat on the skin can cause the skin to get a little drier. So you do want to make sure that when you get out of the hot tub and rinse the chlorine off, you're applying a nice moisturizer so it's not drying you up more. But in theory, a hot tub with the right concentration of chlorine should work just as well as a bleach bath.
Much nicer to sit in a hot tub.
Yes,
least that would be my thing. Okay, so let's see. How is the clinical trial of resiquimod progressing? I don't know if you know. I know a little bit about that. Good results so far, more effective than Imiquimod. So probably a couple of questions there. I don't know how engaged you might be with the clinical trial. I know they're just starting to recruit, and just some of the centers are opening here in the U.S.
Yeah, I haven't heard any results yet.
No, it's brand new. I think, as far as I know, the only results were from the original early stage trial that Dr. Rook did way back in the day, which actually showed the impact, as you were talking about with Imiquimod, that kind of you treat one area and then there's an immune response somewhere else. And from what I understand, resiquimod is sort of the Imiquimod on steroids, if you will. It's a much more powerful version of that type of treatment. And that's why the phase 3 clinical trial is finally opening. We've been waiting a long time for it. And we actually just updated the sites that are recruiting and open on our website. So, but to the best of my knowledge, no data yet. People are enrolling. But maybe you can talk a little bit about, if you know, the difference between Imiquimod and resiquimod.
Like you said, it seems to be sort of a better version of it, seems to really stimulate the immune system more effectively and to target those cells more effectively. And then, like you mentioned, that's one of the big advantages of stimulating your immune system to attack the abnormal cells, is that once you sort of train it to do so, you can see a benefit in areas that you aren't treating, because now sort of your whole immune system has learned to go after the abnormal cells, almost treating them like an infection. So it does seem to work even more so. And then one other little comment is that with the phase 3 trials, which are really the ones that show, in a large population how something's going to work, they tend to not want to share the data until very late in the trial, because say you're going to recruit 200 people for a clinical trial and 90% of them get better, then that means that 20 people aren't going to get better. Well, if it just happens that that's the first 20 people you get, then you don't want to release early results, or it looks like it doesn't work, but it just was bad luck and those 20 people were the only ones who weren't going to do good. So that's kind of one of the reasons that the results won't be out until they have big numbers, because that really makes sure that it gets rid of that random chance that things were just not ready yet.
Right, right. And it's all part of the clinical trial process, is gathering that data and having enough people be part of the trial to look at, how things go over a long period of time. And then once they recruit, once all the people are in the trial and finish up the trial period, then it takes about a year to crunch all the data and do all of the analysis and put their proposal together for the FDA then to review all of the clinical data, and they have to submit manufacturing data, and it's a pretty complex process, which is why it takes so long, and why it's so important for all of us who are patients, if we're interested in clinical trials, to check them out and to see if there's something that might be of interest and worthwhile for us to participate in, because that helps move things forward faster. And then we'll be talking about clinical trials in early stage disease as part 3 of our 3-part series. So that'll be February, and we'll make sure to have someone chatting about the resiquimod trial. Maybe we can fill in some of those gaps, but probably no data. Sorry. Okay, let's see. I've been treated for 2 years with PUVA, UVB, and steroid cream. I'm being referred for total electron beam therapy now. When will a talk cover this radiation type therapy? I'm eager to hear about what I'm in for. So it looks like they're going for total skin electron beam, which is that's a pretty big treatment to go to. I don't know if you want to share about anything. We maybe we'll add that when we're doing light treatment as a variation. So thanks for the question, and Dr. Daveluy.
Because they kind of are similar in that way. Yeah. That would be a good idea to add it on there, because it is like Susan said, it's kind of a big treatment. It can cause some pretty significant irritation, not in everybody, but sometimes. And there's not a great way to predict it. It doesn't, like your response to the UVB or the PUVA therapy. X-ray is really a totally different wavelength. So your response to those doesn't necessarily dictate how you'll respond to the total body electron beam. But it's as with everything, everyone responds a little bit differently. So it's important that you kind of know what to expect going into it and how to handle those things. But also just know that your response may be completely different than what other people have experienced.
Yeah, and I would say if the person is starting total skin before we get to program and we talk in a little more detail, pretty sure we had, I'm pretty sure we captured the discussion about radiation therapy, including total skin, from our Palo Alto patient program back in November with Dr. Richard Hoppe from Stanford, who is one of the world-renowned experts in radiation treatment. He did a pretty scientific review of radiation and total skin. And then the other thing that I would just say is, make sure you talk to your doctor about shielding areas that don't necessarily need to be treated, and what are those kinds of things? What does that all mean? So for example, they sometimes use inserts for your eyes to keep your eyes shielded from the radiation. You need to ask about what all of those different components are so that you're ready. And I also know that for total skin, you have to stand in these kind of weird poses in a funky box, and sometimes that can be a little disconcerting, especially if you have inserts in your eyes and you can't quite see. So there's some of those nuances specific to total skin that you want to make sure you either sit with the tech or have them really review all the nuances around receiving the treatment before you end, just so you've got, so you're mentally prepared, and you don't get surprised.
Yeah.
So I think that would be my non-clinical recommendation from someone who's been through a lot of radiation therapy, but not total skin. But I have had shields in my eyes and done some of those things, and it's not comfortable. And I think you have to have a good mindset before you go in. I think that makes a big difference. Anyway, it's my 2 cents. Okay, let's see. Another question. After my bleach bath, I take a regular shower filled by moisturizer and betamethazone. Is that good, or do I need to just rinse and lotion up?
That can be really good. That's generally what we recommend if you're on betamethazone as a treatment. You hit some really important points there, which are after the bleach bath, we generally tell people to rinse off with some normal water or take their normal bath or shower. Because like I said, having that chlorine on your skin can sometimes make it feel more dry, almost like when you get out of a pool and you just feel tight and dry. So it's really good to rinse off right after the bleach bath. And then, like we said, right after bathing is a perfect time for the moisturizer. And if you're going to be putting something on your skin, then it's a good time to use one of your prescription topicals too. So if you've been prescribed betamethasone, you can sort of use that to the areas that are involved with the cutaneous T-cell lymphoma, and then put moisturizer everywhere else. One of the other things that can sometimes be a little bit confusing with our prescription creams is that the creams, even though it's a cream so it looks like a moisturizer, they often don't actually do a very good job of moisturizing the skin. And part of the reason for that is because they sometimes add ingredients to the prescription topical creams to help them penetrate and get into the skin a little bit better. So sometimes those can almost open the skin up more and leave it a little more open to lose moisture. So generally speaking, most of the topical creams, you can then put a moisturizer on over top of them to help act as a moisturizer, since they aren't really going to do it as well as a moisturizer would. They more focus on getting that medication in where it needs to do its job, but then sealing it with a topical moisturizer can be really helpful. So it sounds like you've got a good regimen going.
Wow. So just to recap, because sometimes I'm slow. So if you are using a medication, it's you do the bleach bath, or even if you're not doing a bleach bath, just your shower or bath. And when you get out, you put on your medication to the areas, and then you apply it would be a good idea to apply your moisturizer on top of that to kind of seal it in. So kind of a multi-part little regimen.
Perfect. Yes, you got it exactly right.
Excellent. Excellent. All right, here we go. I was diagnosed as, okay, I don't think they meant to say psych stage. I think stage 1A recently, with 3 positive biopsies and no other testing, blood tests or anything. Is it recommended to have any other testing? Or that's a great question. So I think a lot of people wonder, gosh, is just a biopsy enough? Should I be doing a full workup? And, you know, do I need a PET scan or a CT scan, or, you know, what kind of testing is good? That's a great question.
Yes, absolutely. So usually for early stage disease where you don't have a lot of involvement, you have those flat patches, a lot of times a biopsy is enough. Sometimes on the biopsy itself, they'll do some extra testing, but it's not anything that you're necessarily involved with or aware of. It's sort of at the pathology lab. They may do some of those special stains I talked about a little earlier. In terms of blood tests, generally for the early stage disease, you don't need any sort of blood test. There's a blood test called a Sézary count. And the basic idea of the Sézary count is it's checking to see, are these abnormal T cells only in your skin, or are they also in your blood circulating around? Generally, for early stage, you don't need a Sézary count, because if you get Sézary syndrome, where those Sézary cells are circulating in your blood, a lot of times the rash will become really widespread, maybe take over almost your whole body. So in that case, it would drive us to check, all right, is this just in the skin it's become really widespread, or is it actually gotten into the blood and that's causing it to be really widespread on the skin? One of the other tests, I was just thinking of one of the other important things, even in early stage disease, is for your doctor to feel for your lymph nodes. And lymph nodes are basically, you have this lymphatic fluid all throughout our bodies. And it helps us fight infections and fight off things that are going on. So when you get an infection in a certain area, your immune cells go back to the lymph nodes and they tell it to make an army of immune cells to fight that infection and send them back out there. And that can cause the lymph nodes to get enlarged. So they're about the shape of a kidney or a kidney bean, and they're usually so small that you can't feel them, but they can become enlarged. So you may have felt enlarged lymph nodes, like if you have a sore throat and a throat infection, you might have some large lumps in your throat temporarily while it fights the infection. So that's why it's important in T-cell lymphoma for your doctor to feel for those lymph nodes, because that would be another sign that maybe the disease is in more than just your skin. If it's gone to the lymph nodes, then it could mean that further testing is required, which could include something like a PET scan or a CT scan to kind of further look at where are they and what's going on. But the good news is for early stage disease, which is where you have just those flat patches, maybe a few thickened areas, but not really thick, and not a lot of involvement in the body, then usually the biopsy and a lymph node exam, just in terms of the doctor feeling for the lymph nodes, can be enough. And when they feel for the lymph nodes, it's usually in the neck, the armpits, and the groin. Those are kind of the big areas where the lymph nodes are clustered. But usually for early stage disease, that's enough. Now, if things don't respond the way that we want them to, or if things change, that might lead your doctor to do further testing. Like, for example, like I said, if the skin disease all of a sudden starts taking over the majority of your skin, then they may need to do some further testing, including the blood tests.
Got it. Great question. All right, here we go. Let's see. Okay, we asked this one, Mike. We did this one. Got the next question. Let's see. Hang in there with us while we work on our technology. We're trying to do the best we can to get. So Mike takes your questions and then he puts them on the screen so I can read them. Let's see. I was diagnosed with MF last time and was referred to an oncologist, which he said, you don't need a treatment. Go home and come every month for blood work, and we take it from there. So I guess it sounds like someone was diagnosed with MF. They were referred to an oncologist, and the oncologist basically said, we'll watch and wait. I guess, any thoughts or comments?
So it's not actually such an uncommon scenario. At our center, we sort of have a team where it's me, the dermatologist, working with the oncologist. And dermatology is kind of a unique field in medicine because most doctors get very little exposure to dermatology during medical school. There's just a lot to learn and a lot of organ systems, and it's such a specialized field that maybe they only have a week or two. And then when you look at the number of diseases we treat in dermatology and the number of creams and how to prescribe the creams, it's really out of the comfort zone for most non-dermatologists to be doing a lot with it. So like for our team, the oncologists for early stage disease, they don't necessarily say, let's just do surveillance, but they often say, I'm going to send you to see Dr. Daveluy and he's going to handle your disease. If it gets worse, you can come and see me. So it wouldn't be a bad idea to maybe start seeing a dermatologist because we're really well versed in treating that early disease, using the creams, knowing how to prescribe the creams, how to discuss the side effects that you might have, how to use them, when to use them, the little nuances like applying a moisturizer on top of a cream, which doesn't seem like it makes much sense until you know why it would be helpful. And then your question also gets to a bigger question that we've sort of had for a while with cutaneous lymphoma is, in those early stages, can we predict who is going to advance to worse disease and who's not going to advance? Who is it? Like in some people, it just sort of acts like a rash, whereas in other people, it can get worse and sort of act more like a cancer. And so for a long time, we haven't had great ways to predict who is going to go which way. And we're sort of working on that with more research and getting more information to sort of personalize our recommendations. But we generally like the idea of treating even early stage disease in the hopes that it will stop it from progressing versus just kind of letting it go. So it may be a good idea to talk to your oncologist about following up with a dermatologist to see if maybe they could do some things to treat the early stage disease, some of those creams we talked about, maybe even the light therapy, just in the hopes that that might prevent it from getting worse, not necessarily that it would get worse or that we have great evidence that treating the early stage helps prevent it, but it just kind of makes all of us feel a little better if we're doing something about it.
Right, and I know that there's a lot of work being done in the clinical and research community to look at trying to determine those things that could predict prognosis. And as we learn more, I think over time, the clinical community will come up with guidelines and treatment regimens and ways of addressing early stage disease. If we could really understand whose disease has a better chance of progressing, then we would then do maybe one version of treatment, where someone has the more, as you said, it just kind of acts as a chronic rash. It doesn't really expand or move, or it reacts well to the light therapy or topicals, then you would go a different route, and maybe have, I know there's some diagnostic testing that's sort of under development that's trying to look at, once we figure out what those prognostic indicators are, then we can start to predict and do a better job, right, of managing the disease out of the box. But until we know that, it's hard to say, and you really have to work with your physician and watch your own skin and kind of monitor how the disease reacts for an individual, because there's no two people whose disease reacts the same way, which is the big challenge. And I think from a patient perspective, one of the more annoying, frustrating, and sometimes frightening parts of trying to wrap your head around this disease.
Yes, yeah, that uncertainty can be really unsettling.
Yeah, yeah. Okay, so here's another question, very interesting. Do you think children outgrow lymphomatoid papulosis? My 12-year-old daughter got diagnosed at 10. She has LYP type B. Overlap, I can't pick, but diagnosis was LYP. Okay, I don't know if what that necessarily is, but the diagnosis was LYP and type B, and do children outgrow it? That's a good question.
Yeah, that's a really good question.
Answer.
Yeah, yeah. And lymphomatoid papulosis is kind of a tricky disease, and we really sort of keep evolving our knowledge about it, because that's one of the difficulties with cutaneous lymphoma and lymphomatoid papulosis, is that they're rare diseases on the grand scheme of things. So that makes it a little harder to study them, because they're just not around. There's not as many people, fortunately, who are afflicted with them. But it makes it hard to really get good predictors, because like Susan said earlier, with LYP and with lymphoma, cutaneous lymphoma, if you've seen one case, you've seen one case. You can't really make too many assumptions about how one person's going to respond. So fortunately, with lymphomatoid papulosis, it tends to be a more benign disease. For anyone who doesn't know, lymphomatoid papulosis is kind of an interesting disease. And the reason it got its name, papulosis, means bumps. A papule is a bump. Lymphomatoid, lymphoma means lymphoma, like cutaneous lymphoma. But oid at the end of a medical term means it seems like it, but it's not really it. So with lymphomatoid papulosis, when they diagnosed the first case, and I believe it was in either the 50s or 60s, they did a biopsy, and they said, wow, on the biopsy, this sort of looks like a lymphoma in the skin. But then they followed the patient and said, well, but the patient did really well. It didn't behave like a lymphoma. So it looked like one on the biopsy, but it didn't really act like one. And so they said, well, let's call it lymphomatoid, like a lymphoma, but not really a lymphoma. So generally, the prognosis is pretty good with lymphomatoid papulosis. There is a risk that it could progress to a true lymphoma, but usually people do pretty well, and sometimes it does kind of go away on its own. So I don't necessarily know that we have data that specifically says in children it's more likely to go away, but even in adults, sometimes it sort of clears up after a certain amount of time. Other times it'll come and go. It'll clear up for a while, and then you'll sort of have a crop of new papules show up. But the good news is that overall it has a fairly good prognosis. But it's kind of a tricky disease, and it's rare, so we don't have great data to say what it's going to do in any one individual, and you just kind of have to keep following with your doctor, and you adjust the treatment based on how it's doing. And sometimes the treatments can be just topical creams. Sometimes we move toward pills, like there's a pill called methotrexate that can be really effective for lymphomatoid papulosis. But of course, you have to balance the risks and benefits, especially in children. We're always a little bit more cautious with some of the treatments that can have side effects. But it's something to kind of discuss with your doctor and see how it goes. And unfortunately, I don't have a really great answer. But like I said, usually the prognosis is pretty good with lymphomatoid papulosis.
Yeah, thank you. Okay, so do you have any feedback or recommendations for treating with protopic, tacrolimus? And what do you feel like is the safest treatment to use for MF on the face?
So that's a really good question. So tacrolimus is related to a medication called cyclosporin. It's sort of a cousin of it, and it's available as a cream. And cyclosporin can really suppress the immune system. So we use it for organ transplant patients because you don't want their immune system to attack their new organ. So we can really inhibit their immune system to make sure that it doesn't. And then sometimes we use it in some of our skin diseases like psoriasis or even severe eczema because it's that same idea that it stops the immune system. So that's the oral form of cyclosporin. Tacrolimus is a topical form, and it was approved for eczema or atopic dermatitis. And people really like to use it on the face because steroid creams can have a side effect of thinning the skin. Generally, if you only use them to treat when your disease is there and you don't overuse them when it's cleared up, then the risk is pretty low and it's pretty safe to use them if done properly. But it's always a little bit chancier on the face just because the skin's a little bit thinner there to begin with, especially if you're talking about around the eyes and the eyelids, and there's always a concern about getting steroids in the eyes. So that's one of the areas that tacrolimus has been popular. The results with cutaneous lymphoma haven't been as great as they have with atopic dermatitis. So it's not one of the treatments we go to a lot. I usually talk with my patients more about the safe way to use steroids. One of the, even on the face, one of the interesting things with cutaneous lymphoma is that it tends to show up more in the places that don't get any sunshine, which is one of the reasons that we started using light therapy for it, is because the light therapy has sort of part of the wavelength of the sunlight. And so cutaneous T-cell lymphoma especially likes areas that are sort of double covered by clothes. So like under the bathing suit area or where your underwear cover, where you're wearing underwear and pants. That tends to be one of the most common places for it to show up. So a lot of times it's not as severe on the face anyway, and we think maybe that's just because of the day-to-day sunlight that you get, just living your life and going out in the sun a little bit. But tacrolimus can be used as an option especially if steroids want to be avoided. So I don't want to necessarily say it's not a great option, but it doesn't have as much evidence that it works very well versus the steroids, or say the Imiquimod could be used for limited disease, or even the Bexarotene that I mentioned earlier. It's been used in acne, which of course then we use it on the face. So that's another good choice for the face if you want to avoid the steroids. And it's, like I said, not that tacrolimus necessarily isn't the greatest. It just doesn't have as much data to show that it really works when we try to use it on a large group of people and see if it'll work out.
Right, right. So always a challenge. I think the face sometimes, is really those areas. It's really hard, just because it's you're out in the world, and so even if you just have a small patch, it could be devastating because that's what you see all the time. You look in the mirror and it just keeps showing up, right? So even if it's easier to hide something that is in your bathing suit area because no one else sees it except for you, and maybe even not you, unless you hold a mirror behind you. You know, so it's not as bothersome, right? So good points. Let's see. Is there a website that have different photos of MF? I would like to compare picture clarity. Unsure if I'm just in denial. Let's see. Other than our website, we tend to have some of the presentations that we've done, and we have the PowerPoint, have pictures of the different, you know, patches, plaques, and tumors, but I think it's really hard to compare because I don't know of anyone's disease that looks the same. It may be similar, but I think that's really hard.
Yeah,
I don't know if you have any other thoughts.
Agree. And like Susan said, the Cutaneous Lymphoma Foundation website has great information, videos of old presentations that can kind of go over some of the findings. But it is really hard. And it is really hard, like so dermatology training is 3 years. And I'll tell you, even after a full year of just dermatology training, the residents usually still have a hard time of identifying lymphoma. And that's after seeing people with skin disease, 30 to 40 people a day for a full year. They still have a hard time identifying it because it just doesn't have that signature look that some diseases do, like psoriasis. If you see some classic psoriasis, it's a slam dunk. You know exactly what it is. You can spot it from across the room. But cutaneous lymphoma is much trickier. Sometimes it can have some sort of that classic look, like I said, where it's in the bathing suit area. The skin looks a little thin and crinkly, but it doesn't always look that way, and that's not reliable. So it's really hard, but the Lymphoma Foundation website is probably the best resource to kind of look at things. One other website that may be helpful is it's called DermNet New Zealand, and it's from the country New Zealand. And it's basically, they've sort of collected images of a lot of skin diseases to share with doctors, with patients, with everybody to kind of get a good look. But like we said, it's really hard. It is a tough disease to get a grip on, and it can show there's different types, there's different forms. It can show up as patches that are flat, plaques that are thick, tumors. It can just look a lot of different ways, which makes it really hard to identify.
Yeah. Yeah, I wish we had a better answer for you on that one. But okay, so we have time for 2 more questions. So here we go. I'm 12 years out from a heart transplant, blessed. Congratulations, that's amazing.
Yeah.
Have you heard, are there lots of cases of immunosuppressed people with this? And does that cause another set of treatment problem options? That's a good question.
That's a really good question. It's really interesting. I haven't necessarily heard of a lot of immunosuppressed patients with cutaneous T-cell lymphoma. On the converse side, it's kind of counterintuitive sometimes the way immunosuppression can affect the disease itself. So you would think to yourself, these are immune cells, and so I should, if I wipe out my immune system or really weaken my immune system, it should get rid of my disease. But there's kind of this interesting thing that happens with cancer where your body, actually your immune system, tries to fight cancer when it shows up. And so there have been many cases of cutaneous T-cell lymphoma that they might be misdiagnosed as another disease. And so, like I mentioned earlier, cyclosporin is one of the medications that we use in transplant patients to help make sure that once you get that vitally needed organ, you can keep it and it'll keep working and your immune system won't attack it. If someone sort of mistakes cutaneous T-cell lymphoma for, say, psoriasis and gives cyclosporin, it can stop the immune system from fighting the abnormal immune cells. And even though maybe the immune system wasn't doing a great job, it wasn't wiping out the disease, it was still fighting it. And when the cyclosporin sort of stops the natural immune system, the healthy immune system, from fighting the T-cell lymphoma, it can be like throwing gasoline on a fire and make it worse. So it sort of makes sense to me that in some patients who are undergoing immunosuppression for organ transplant, if they had just a tiny touch of the T-cell lymphoma that was trying to get a footing, then when we weaken the natural immune system, the healthy immune system, it might sort of give it more opportunity to grow and to proliferate. Sometimes we do end up using immunosuppressive therapies to treat the T-cell lymphoma, but we try to save it for a last resort. We try to sort of modulate the immune system and allow the immune system to help us fight the T-cell lymphoma before we weaken the healthy immune system with the abnormal part, the T-cell lymphoma. So I can't say that I've necessarily read a lot about transplant patients showing up with T-cell lymphoma, but in my head, it sort of makes sense why that might occur.
Right. I think that, you know, that would be a very interesting study to do at some point in time. Okay, so here we go. Can topical vitamin D treatment, oral vitamin D supplements help suppress or manage MF?
So when it comes to the topical or oral vitamin Ds, we don't have great evidence that they really help MF. They're available mostly for psoriasis, and we found that we could sort of deliver vitamin D in a topical form, and it seemed to really help psoriasis. There's not as strong of evidence for MF. There's been some cases reported where people felt like it helped, but not really the large trials to show that it's a big benefit. It's kind of not necessarily counterintuitive, but interesting, because that is in some ways what we think the light therapy, one of the effects it may have is to increase your vitamin D, because when you get some UV light exposure to your skin, it produces vitamin D. It actually produces a precursor, then the liver converts that into vitamin D. But there's not really great evidence that vitamin D supplementation on its own can help cutaneous T-cell lymphoma. In general, vitamin D has been a little bit of a tricky thing to study. And there's a number of reasons. Sometimes it's a matter of not really knowing how vitamin D interacts with different diseases. In some diseases, high vitamin D seems to be bad. In other diseases, low vitamin D seems to be bad. But then there's even some more recent evidence that the way we test vitamin D isn't always really that accurate. So maybe the associations we've made aren't great. So it's out there and it's proven to work well for psoriasis, not as well proven for MF. So in general, I would say it'd be better to stick to some of the therapies that work well. And then if those aren't working, it might be worth giving a vitamin D cream a try, or using it in combination with something that is proven to have a benefit.
Got it. All right, one last question, and then we'll let you go and enjoy the rest of your evening. I'm 29-year-old female, and I know usually this is a disease with older males. Is there any precaution with pregnancy? That's a great question. I know MF involves the immune system, and pregnancy or giving birth affects the immune system. There is not a lot of research that she has found. And so just as someone also that was diagnosed when I was 31, definitely not the norm, but again, not unusual. I guess that's the question. So yeah, I think these are really great questions in women who've been diagnosed, and probably men as well. If you're younger, what are the things they need to think about if they are planning to get pregnant, and side effects of any of the treatments that may have an impact on fertility, or any ideas or thoughts around that?
Right. Yeah, that is a really great question. And it is kind of unfortunately one where I don't have a lot of great answers. So we don't have too much evidence that the disease will affect the pregnancy. Like some diseases make you less likely to become pregnant or to maintain a pregnancy. But like Susan commented on, one of the main areas that you may see sort of the pregnancy come into play is in terms of the treatments. So like I briefly mentioned, the Bexarotene is a treatment that we don't use in pregnancy because the oral form definitely causes birth defects, and we don't have enough proof that the topical cream is safe to use in pregnancy. The topical steroids, they have been proven to be safe as long as you don't go over a certain amount. If you use too much of them, you may get some absorption, and it's shown that that may increase the risk of a cleft lip or cleft palate in the baby. So they're still pretty safe, but it's something that you would want to talk to your doctor about. And then definitely if it became sort of more progressive, then some of the other therapies that are beyond the skin-directed therapies, that's always a discussion to have in terms of pregnancy, safety. And pregnancy is kind of funny when it comes to skin disease in general, and actually most inflammatory diseases, because overall pregnancy does have sort of an immune tolerance phenomenon where we see the immune system calms down a little bit while you're pregnant. And we think that the idea is that since the baby is actually foreign to you and has half of its DNA is different, you don't want your immune system to all of a sudden detect it as something foreign and attack it. So the immune system calms down a little. So for some diseases, that can really help. Like in a third of people with psoriasis, it'll get better. In people who have lupus, which is an autoimmune disease, for many people, it will get better. I don't know that we really have good evidence for cutaneous T-cell lymphoma patients for how it reacts with pregnancy. And that may be a product of the fact that the disease is more rare. So the number of people who have become pregnant after being diagnosed is probably a very small number, because even psoriasis, which is a way more common disease that affects 1 to 4% of the population, we don't even have great data for it. It's been long coming to get that data. So unfortunately, it's kind of another unknown area, but that's what would be really important if you are planning to get pregnant, would be to talk to your doctor about the treatments that you're doing for your cutaneous T-cell lymphoma, to make sure that those are all okay during pregnancy. The light therapy is one that is generally considered safe during pregnancy, so it can be a good option if it's working, and something that you can maintain through the pregnancy if it should happen.
Yeah, and I'll also put a plan. We have updated a section on our website with regards to fertility. We had some help from clinicians at Sloan Kettering who were specializing in fertility, and I think we still have a little bit of work to do on that, but we're trying to pull together as much data as we can to give people an idea of the impact and which drugs would have more of an impact than others, or which treatments that would have more of an impact. And feel free to drop us a note, and we can certainly try to send you in the right direction with all of that. And I'll also say that I know one of our board members who has been living with MF for over 30 years also had children when she was diagnosed way before me. And actually another one of our board members, a gentleman, also had children after he was diagnosed. So hopefully that gives you a little bit of comfort as you kind of go through that. But I would say always discuss everything with your physician and let them know that you're thinking of becoming pregnant, and really have a discussion around the impact of that before you do any kind of treatment. So that kind of concludes our evening together, and thank you so much. And it was great. And as always, thanks to our amazing audience for their unbelievably great questions. There's always something that is new and interesting, and I really appreciate your willingness to answer some of the ones that we don't always have great answers for. But thank you so much for joining us, and we really appreciate your time and your energy and all of your the work that you do for patients in Michigan.
Yes,
so,
and thank you, Susan, and thank you to the Cutaneous Lymphoma Foundation for all the excellent, amazing, awesome work that you do to really go above and beyond for patients. It's just a great organization and a great resource for all our patients.